We're going to go to HA filler selection, injection techniques, because Kent was showing you a lot of the techniques that we've worked out together on how we use cannulas and needles, when we use cannulas, when we use needles. Again, this isn't written in stone, right? This is just how we evolved. When I first saw some of these products being used back in the mid-2000s, in Europe, I watched 12 excellent injectors inject in 12 different styles, and they all got beautiful results. What we're really interested in over here is the idea that if you have a way of driving your car, stick with it. I don't want to change the way you're driving a car and you getting into an accident. If you're comfortable in using needles or you're comfortable in using cannulas, that's fine. Just understand the science of what you're injecting, and you'll understand which one may be preferable in certain areas. So for me to tell you to drive a car the way that I drive a car, don't do it. Okay? Just think about it. Say, yeah, maybe I'll indoctrinate this into my practice. Maybe I won't. What we really want to make sure is that we have the same destination. The companies are doing an excellent job of providing us with amazing products. These are very high performance products. They are not the products that came out of the 90s. These are very high performance, and they all have their own personalities. We're going to take a look over here. So what we want to make sure is that our destinations are the same. So where our goal is, where we're trying to go, our destination is the same. If you want to take a car, you want to take a plane, you want to take a train, I don't care. As long as we get to the same place and we do it safely. That's the key, okay? So what is a hyaluronic acid? Remember, you're dealing with sugars here. And it's a sugar that's found throughout nature. It was discovered in 1934 by Meyer and Palmer. In an article they called the polysaccharide of vitreous humor. They took it out of cow eyes. And it's there it was, the vitreous of cow eyes. And it was first used therapeutically in 1970. The thing that's key about it is that it's identical in all species, and it's been shown that we do not need allergy testing for this, for the HA, okay? So in the human body, there's large amounts found in the skin. It's naturally degraded by the body. And I found this little thing, which I thought you might enjoy. Do we have the volume up on this? It's called the Village of Long Life. When I was in Japan, Yuzuri Hara is called the Village of Long Life. It's a very interesting thing. Kent, I think you'll enjoy this too.
This village may look like just an average Japanese town, but some medical researchers believe it may actually hold the key to the fountain of youth. They discovered that people here routinely live into their 90s and beyond, rarely have any reason to go see a doctor, and somehow have managed to prevent even their skin from aging. What's behind this secret phenomenon?
What the villagers eat gives them an abundance of a substance called hyaluronic acid, more than most of us have in our bodies. HA, as it is called, is something we're all born with but lose as we get older. In our bodies, HA enables cells to retain moisture. It keeps our joints lubricated and our skin smooth and elastic. The same qualities Dr. Komori finds in these spry, smooth-skinned villagers.
'85 plus you're looking at. You think there's something to HA beyond the fact that they absorb water? Absolutely. We're seeing that there's biological effects of these products. They eat a certain type of tuber that they grow in the ground that gives them amazing abundance of HA. And their skins, look at the skins on people who are aged 85 plus. The vegetable-rich diet has been shown to promote high levels of HA in the body, responsible for the wrinkle-free skin. So with HAs, their functions include skin hydration, they're lubricating agents for joints and shock absorbers for the retinal cells. They can hold large amounts of waters. 1 gram of free HA can bind up to 6 liters of water. Okay, so they're very hydrophilic. And their commercially available HAs have very extensive applications in many medical disciplines, but there's a 25-year history now of aesthetic use for wrinkle correction, which was, the charge was led by the QMed product when they brought out Restylane onto the market. Corneal was there as well. So the history, 1981 to 1993, the wrinkle filler market was dominated by collagen. First publication of HA filler for aesthetic use was in 1998. It was Restylane for lips, wrinkles, and folds. And the introduction of Restylane across the globe was transformative. When that product came out, it started to transform the way that we were doing things, and all the other companies sort of jumped in along as well. If you take a look at the dermal filler use in 2009 in the U.S., in 2009, look, HA fillers are dominating the market. The other products have become more of niche products, and products that are used, with a little bit higher expertise or in specific indications. So there's a very little events of adverse reactions. There's non-immunogenicity. It's predictable, reliable, and reproducible. More than my slides, it appears. There's durability, relative ease of use. Artistry and rheology is why I use it, because of the fact that I feel like I'm painting with big brushes and little brushes. And there's biostimulation and biointegration, like Kent was talking about. And reversibility is key for me. I must have an eraser for the things that I do, and for a lot of the things that I do. And I like the idea of knowing that when I go home and go to sleep at night, that I can reverse myself out of situations, as we'll see when we talk about it a little bit later. This is basically the way that all the companies look at their HA. They get it as a powder. It's literally sugar. It comes as a powder, and then they add a solvent, but if you take a look at it very carefully, it's just water. It's a buffered water that they add in, which causes what they call linearization of uncross-linked HA. The HA actually picks up an electrical charge and starts to linearize. It becomes a liquid. If you were to inject this, it would last probably about 15 minutes. It was the most expensive product that was on the market back in the old day when we had Hyaluron, because you had to reconfigure your office to change your secretary from being in the front of the office to next to your examining room, because if the patient went to the front of the office, the product was gone. You had to pay before they left. And then they get a gel by putting in the crosslinker. Most companies use BDDE. The BDDE crosslinker gives it robustness and turns it into a gel. And then from this point forward, whether you're Galderma, whether you're Allergan, whether you're Mertz, whether you're Tioxial or Tioxane, from that point forward is the proprietary thing that the companies do to their products, that they say this is what gives them their characteristics and their definitions. Okay? But up until this point, it's all the same. So it has a short half-life of about 1 to 2 days if it's a native HA, and the cross-linking process is necessary to stabilize it. The type and efficiency of cross-link and individual proprietary modifications determine each HA-specific property. So what makes a commercial HA filler, cross-linking, treated indication, purity, biointegration? They spend a lot of time in making the rheological properties. Most companies now are doing all this stuff backwards. So they don't go ahead and develop an HA and then say to you, oh, this looks like an HA that you should try in this place or that place. They take a look at what the rheological properties they want within the HA and say, if we want to put a product in deep and we want it to be able to lift, it's got to be a little stiffer, they end up with a higher G prime product. Oh, if we're putting a product that's underneath the lip and we want it to spread, we need a little bit of cohesivity, so they adjust it that way. So they actually are trying to tailor their products back to where your indications are, rather than saying, here's a product, go find out where it works best. Okay? So it's an interplay of cohesivity, elasticity, plasticity. So is there a good HA and a bad HA? Why do people say to me, I don't understand, you talk for Galderma, you talk for Mertz, you talk for Allergan, you talk for all these companies. How do you do that? Because I don't believe there is an evil HA. It's just HAs with different personalities. They're like your children. You have some children that love to stand up and run around the room and be noticed, and others that like to lie down and be quiet. I wish I had those. The ones that want to lie down and be quiet. And that's exactly with the HA. Each one, like your child, has its own personality. So you match the personality of the product to what your goal is. Take a look. Poor aesthetic outcome from inappropriate choice of both product and injection technique. A product with too high of a G prime that was put in under the eye that caused an ectropony of the eye. A product over here that caused a blowing out of the lip. So how do the companies check for this stuff? They check the stiffness or hardness of the G prime by giving it a squish and a turn. This product, which completely recovers, you can inject through a syringe. This product is partial recovery, you can, and this, if you injected it to somebody's cheek, they'd wake up the next morning, it would be flat. So all the products from all the companies fall somewhere between here and here. They're somewhere in this range. That's how they check for the stiffness. They take the product, they put it between two plates, they press it down, and they torque it. And they see, does the product start to break out? Okay? Now, for cohesivity, what they do is they just squish it and see, does the product stay together? This is a highly cohesive product. This is a product of lower cohesivity. And this is one that's not cohesive. So if you were to put it in a product that had absolutely no cohesivity into the tear trough, would you want this? The answer is no. So you have to understand where the interplay is between your products. Okay? So what are the common myths about the HAs? Particulate versus non-particulate, that's a lot of BS. Every single HA is particulate. because it comes as a big glob, and they have to break up the glob into little particles to be able to inject it. Look at all these different HAs over here. These are all from different companies. They're all particulate. Okay? So if you hear about particulate, non-particulate, it's BS. Then they talk about, well, monophasic versus biphasic. That's also BS. Why is it BS? Because phase refers to the fact that you can exist as either a liquid, a gas, or a solid at the same time. That makes it biphasic. Like here, ice and water. If you take a look at really all the HAs, they are all biphasic. They all have free HA, which is a liquid type of form, with the solid or gel form to be able to allow the rheology to put it through a syringe. See, this is what they look like. They come out in a monophasic area, and then they all make them biphasic by adding in the free HA. A gel must be stiff to project and soft to spread. Isn't that what you were told? I'm bashing all the myths here. Does a gel have to be stiff to project and soft to spread? The answer is no. G' and cohesivity are terms used to describe gel characteristics in vitro. You know where they come from, those terms? You have to understand, there were no gels. It was all collagen. Then all of a sudden, I think, the way I like to think of the story was, they developed a gel that was supposed to be put into knee joints in order to be able to replenish the lost HA in knees or in eyes. And I have a feeling that at some point, one guy was injecting the knee, and as he pulled it out from the knee, he left some of the product underneath the skin, and he noticed that some of the wrinkles of the knees were gone. And then bingo, the next thing you know, we're starting to see HAs that are being put into the face for aesthetic reasons. But the G' and cohesivity things that we talk about, G' in terms of kilopascals and cohesivity in terms of gram force, comes from automotive gels. That's the only descriptions that were around, was to describe how do gels perform when they're working in cars. And so the companies had to take those terms and bring them into the medical field to be able to describe their gels. So how much does the environment in which you inject determine a product's performance? Isn't that the key? Where are we injecting it? That's the whole idea. Their tests are done between two plates in air. But guess what? I don't inject birds in air. I'm injecting people into their fat or into their muscle or onto the bone. You'll see tests for cohesivity where they spin it in water. It's a beautiful visual demonstration of how cohesive the product is. But guess what? I don't inject fish. I'm injecting people. And so how much does the product react here? Saline has a cohesivity of 0. A G' is unmeasurable, 0. Watch what happens.
This is about my lips. Okay, now look at me. I want Tina Turner. I want Jagger. Fill them up.
Remember that from First Wives Club? And that's what you look like. That's saline. Saline has lift, saline has cohesivity if put into the proper medium. It won't last. But if you want to talk about pure terminology, that's what it is. So you'll get all these values of rheology about stiffness and everything, but the understanding is you have to understand the interplay between all the companies of their stiff products and their not so stiff products and their cohesive and not cohesive products. And when you understand this, you don't have to get into a lot of detail. When you understand this, you'll understand, where do I inject it? Okay? See this? I got fed up of hearing about cohesivity and G'. Because I said, you keep on telling me about things that are occurring in automobiles, but I want to see what happens in people. So what I did was I took abdominoplasties, patients who came to see me that had tummy tucks, that had very thin tummies, that wanted to have their skin and fat removed, very little amount of fat, about the amount that you would find here. This is blown up. This is the amount of fat that you would probably find over a cheekbone. This is the skin. This is the deep area over here. The bone would be down over here. And I said, you know what? I'm just going to dye some products, and I'm going to inject it into the flaps before I go ahead and remove the flap. Then I'm going to remove the flap. I'm going to remove the flap. I'm going to put a 10-pound weight on it because your head weighs between 8 and 11 pounds. So I filled up a sterile bowl with saline during the time that I was doing the surgery. So the surgery would take me an hour and a quarter, an hour and a half. And then afterwards, I would section it open and see what happened to the product that I injected. I won't tell you which product is which. Which product has cohesivity but no lift capacity? See that? It sticks together, but it compresses. Which product has a combination of cohesivity and G'? Which product has very little cohesivity and spreads? So this is what happens in the tissues when we're injecting it. So back in 2003, Kent and I talked about facial reflation, thinking beyond the lines. People looked at us and said, you're crazy. And that, you can ask Kent. When we were doing our facial reflations back in the old days, and ask Kent about this, I'm asking you guys, what was the average number of syringes that I was using per patient? How many people here think I was using 4 syringes or less? God, I can't get a bite. 5, 6, stop me guys, 7, 8, 9 syringes? You think I was using 9 syringes per patient? You know what I was averaging? 15 syringes per patient. How many patients do you think could afford that? I was charging $6,000 to do facial reflation because I had so much product that I had to put in. And people would say to me, you're out of your mind. They tell me that all the time anyways. I said, you're out of your mind. How could you put 15 syringes into a patient's face? And you know what our answer was when Kent and I were asked about this? It's a tablespoon. It's 1 tablespoon. You don't need a tablespoon to fill a face? Oh yeah. They'd say, oh yeah. Well, we were wrong. Why were we wrong? Because we were thinking in terms of volume. And I told you before, volume is a terrible thing to think of when you're thinking about HA fillers. HA fillers weren't designed to give volume. I'm sorry. That's not the way that newer robust fillers were designed. Because this is 1 cc of product. You're going to have to put in 15 cc's to fill that syringe. That's because now I use an average of no more than 4 cc's for a total face. How could I go from 15 down to 4? 15, I would do maybe 1 or 2 patients a month. I was seeing maybe 20 patients a year who could afford it. Now with 4 cc's on average, every patient is a candidate. If you price yourself properly, you can do these full face things properly, like Kent was showing you. You saw he was doing the whole lower face. He had that same syringe in his hand. How was he doing that? Because I am a fat injector. I was trained in plastic surgery. I started doing fat back in the 1980s. Sid Coleman and I were busy banging patients around and putting in fat into the face. And this is why I was thinking. I was thinking, fill, 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 fill. You gave me an HA, I had to fill. You don't fill with HAs. Okay? This is the volume that you get when you fill up a tablespoon of 15 cc's. It's a fill. We're projecting. This is 1 cc of product. Look at the way it stands up. Look at the contour that you can create. You're creating a tent pole, which is what Kent and I talked about in an article. You create a tent pole with a canopy over it. You don't have to fill the entire face. It's projection. That's the key. And bringing the calipers into it to show you where you should be projecting and creating light and shadows is all the difference in the world. So Kent's little animation here is on point. You find the depth of where you want to inject the product. It's going to be underneath the muscle, into the little areolar tissue above the periosteum. You don't move your needle. You just let the product do the work. It wants to lift, let it lift. Isn't that the idea? Create the tent pole, and the tent will follow over it. Look, here's a product that's being injected that was meant to lift. This could be Voluma. This could be Belotero Volume. This could be Perlane. Look at it. It's standing on its head. That's 0.1 cc's. This is 0.1 cc's. Why would you want to do that? Because we've been trained to go after the skin. Well, guess what, Dorothy? We're not in the skin anymore. We're not in Kansas. We're not injecting into the skin as much as we were doing before. And if you trace it anti and retrograde, you do that like Kent and I do when we're subdermal sheeting, we're subskin structuring. You can do that. But if you want to project, which one projects more? It's kind of obvious. Let the product do the work for you. I am the laziest injector you'll ever see. Hopefully, you'll see me fall asleep as I'm injecting when I'm going in this afternoon. I like to put the patients to sleep with my talk aesthesia, and then I take a snooze at the same time. You stick the needle, like Ken showed us in his cases, he sticks the needle where he wants the product to go, and then he lets the product do what it was designed to do. You marry the anatomy to the product. So, if I'm putting product into a tear trough, if I'm putting product across a forehead, if I'm putting product across a lip, I want the T1000. Remember that guy? He was the silver guy in the movie that loved to stick together. He liked to have some cohesivity and layer out flat. I want to be one big puddle, not a bunch of little puddles. Otherwise, you're going to see the little puddles. And that's why I'm a horrific blender. Sometimes I blend my products to get them to the qualities. It's not that I'm smarter than the scientists who are doing this. I'm just understanding what my goals are. So, when I do a forehead, I measure the forehead to 12 to 14 degrees, as we were talking about before. There it is. You can see the gap between the caliper and her forehead. I'll then show you the technique when we do it this afternoon. Using small needles, because I like to use small needles around the orbit or in the forehead because I deliver small amount of product over a small amount of time. It's just a little pinch. Vertical placement on bone, very small aliquots, typical volume. Look at the volume I'm using for an entire forehead, 1/4 to 1/2 cc. How do I know I'm safe? We're going to talk about that after lunch. I avoid the high-risk areas, and look at my products of choice. It could be Volbella, Volif, Belotero, Belotero Balance, Restylane Silk, Emerald Touch, Emerald Classic, whatever you like. Because I understand that these products are going to work well for the way that I want to do them. Okay? There are nuances that if you really get into it that allow me to choose one product a little more than the other, but they'll all be able to do a very good job. And look at her afterwards. Okay? Look at the back of the forehead. I just turned it away. You can see the back of the forehead. The other side hasn't been done, but now she's smooth. She has that contour that you want. For the temple, for hollowing and brow shaping, it's such an easy thing. I choose a product that I want to lift and spread. I find my ideal point. It's the one injection point that Kent was talking about. I start the flow of product slowly. I put my finger behind there so it doesn't spread underneath the scalp. Vertical puncture, 1 centimeter up, 1 centimeter back, typical volume. We'll show this afternoon. And there's all my products of choice. Voluma, Volift, Emerald Volume, Emerald Deep, Belotero Volume, Belotero Intense. Okay? Can you speed that up for me, please, if you don't mind, and bring it down to about 9 seconds? Because look how slow we inject. We are very methodical. The slower you are, the better the injector you are. I'm sorry, you went a little too fast. Just take it back and click it up to, I'll start it. Oh, there you go. Take it up to about, yeah, that's good. Leave it there. Let it run. Watch what happens to the eyebrow when you inject the temple. Watch what happens to her eyebrow when I injected this temple. This was on stage. Look at her eyebrow. What happened to it? Up and out. How's that possible? Is there a muscle that I've injected in that area that lifts the eyebrow? No, it's a muscle of mastication, temporalis. How does that eyebrow go up like that? How does it stay up like that? Do you think it's the lidocaine effect? What's the lidocaine affecting? There's no muscle there that it's going to be able to soften. And if it was orbicularis, which it isn't, the eyebrow would have come down. Why is the eyebrow up? Aha. You got to ask yourself these questions if you're doing this stuff. We're really going to get into it this afternoon because I think the muscles are talking to each other. I think when you fill the temple, the frontalis that's sitting next to it says, whoa, look, the temple's full. It doesn't have to do any work. I might as well do a little more work. And it starts to lift. I haven't injected the frontalis on her. We're going to talk about that. Vertical puncture, all this type of stuff. It's a very simple technique, and it's a safe technique because we understand the anatomy. I'm going to go through that. I'm flying along here because I got to finish in 6 minutes. Temporal crest fusion line, 1 centimeter up, 1 centimeter back. That's our injection point. You go right down onto bone. You must be on bone here. You start the flow of the product. When I go through the anatomy with you guys, which will take me 20 minutes, I made the promise to some of my colleagues outside. I'm going to do the anatomy, and Kent and I are going to go through it on a patient that's up over here, on a model, and then we're going to inject. You're going to be the brains. I'm going to be the hands. You're going to tell me from the anatomy that we explained, what's the depth of my needle? Where am I injecting? You better get it right. Kent is there to make sure that we do it right. But here's my promise to you. For every time you get it wrong, I'm taking off a piece of clothing. And you don't want to see my legs. You don't want to see my legs. Not a pretty sight. Beyond the other stuff. I have yet to get down to my underwear and injecting. It's a situation that I'm going to simplify the anatomy so that it becomes very straightforward. And you understand that when you inject on bone over here and you start the flow of product, it will lift, hit the undersurface of the deep temporal fascia and start to spread. You're not moving your needle. You're allowing the product signs to marry to the anatomy. It's doing all the work for you. And this area here where we don't want the product to go, you put your finger to stop it. And that's it. The simplest injection technique that you can imagine. As you start to squeeze the product, it will spread. And that's exactly where you want it to fill. That's the deep temporal fascia that's going to allow it to spread. Your finger's going to stop it over here, and you get the results. So if you look at it in an animation type of cross-section over here, we're going down to bone. The product is going to ride up because it wants to stand up. It hits its head on the ceiling. Right here, deep temporal fascia, and then it runs along between the fascia and the bone. The fascia and the muscle. All with one injection point, instead of dancing around and bruising the patient. Right? This is going to be exciting when we do it. This is not my patient. This is a cadaver. Sometimes I want to open my patients up just to keep them quiet, but I don't. But this is my patient. This is my patient. This is the cadaver. This was done when we were in China. This is the temporal fusion line right here. There's the temporal fusion line, temporal crest. This is the orbital rim. Eye, nose over here, just to orient you. This is my blue stuff, my injection that had blue dye in it. This is the deep temporal fascia protecting all the vessels here. Look underneath. The deep temporal fascia, superficial temporal fascia. It's all protected. Where was my injection point? 1 point. 1 centimeter up, 1 centimeter back, right there. And the product will spread for you. You don't have to start to search. It's great. And this, Kent was showing us with the infrabrow hollow, which I call it that, so it becomes on label. That's a little trick for the people who are here from industry. It's not the A-frame deformity, but it's infrabrow hollow. Oh, okay, you can inject infrabrows because we're allowed to inject brows. Oh, okay, great. See that A-frame technique? This is exactly what Kent was showing you. I have a tendency to use a 27-gauge cannula like he was talking about because it's longer. The fact that it's blunter, so if I happen to sneeze or something, I don't go through the eye. It's always a good thing. And watch how superficial the injection is. It's a lateral approach. It's a 27-gauge cannula. I'm going to lift it up just to show you over here how superficial it is. Here it goes. It's sub-Q, and it's just below the supraorbital rim. Lift it up, Artie. Come on. Attaboy. There you go. Look how superficial it is. You're in a plane above orbicularis muscle. In a plane above the orbital septum. People say, oh, I inject between orbicularis and the orbital septum. Have you ever tried to dissect that out when you're doing surgery? It's impossible. Product of choice, I use 50-50 blends around the eye. And we'll talk about that afterwards. I can talk about anything I want because this is CME. I use Resti, I use Resti Silk, Bellatero Soft, Dermaville Touch, Redensity 2, Volbella. I use products that have a 50-50 blend because I worry about this. This delayed edema, when Ken was nice enough to let us have this slide, show a patient that was treated somewhere else that walked in that had this edema that occurred 5-6 months later. Of course. You're injecting an HA that loves water. You're injecting it in an area that the skin is so thin that any expansion of the product will show through the skin. The patient leaves the office, looks great. Mistake number 1. They should never look good in the infraorbital area if they leave. They should be wanting. You treat to 70%. Now the patient goes out, looks great, and she decides a month later that she's going to go out drinking with her girlfriends, or she breaks up with her boyfriend and starts crying, and she gets all swollen, and that product is sitting there and waiting for the water. This is what happens. You have to undertreat there. And I thought, well, if the product wants water, why not give it the water that it wants? Why not inject a wet sponge instead of a dry sponge? You inject a dry sponge, it wants to absorb water. If you already give it the water that it wants, maybe it won't ask for much more. So I have a tendency to blend. That's my technique. I'm not saying you guys should do this. You have to be sterile with it. We can talk about the ways to do it. But this is what I found has dropped down my incidence of periorbital edema practically to 0. Okay? And you massage the patient, just like Ken showed you afterwards. It's a gentle massage. That is a youthful eye. A youthful eye has volume on the top with a crease that follows the ciliary margin. You can see that. This is older and scalloped out. And that's Ken showing me with a thumbs up that he was happy with what I did when we were doing this patient together. We worked on her together. Okay? I showed you this picture before. Lateral canthus, again, we talked about this already. To inject lateral canthus, I use small little boluses. Why? Because I understand the anatomy, and we're going to talk about that later this afternoon. Understanding the anatomy means where I'm injecting right now is in the SUF. It's in the suborbicularis oculi fat. It's actually a glide plane that's under there for the muscle to glide over. So I'm safe to put it in there without putting it into the muscle. Again, 50-50 blends is what I like over there. Here's the bilamellar approach. Tear troughs, as Ken says, the easiest area to do, poorly. So I use a 2-layer approach, and I'll explain to you why. Very quickly. The orbicularis, watch, this is the superficial layer that I'm putting in. Watch how superficial the 30-gauge cannula is. And this patient's never been injected before. Never. Okay? This patient hasn't been injected before. Look how superficial the cannula is. It's underneath the skin where we used to do skin flap-only surgery when we did lower lids. They don't even feel it. It glides like butter. If it's not like butter, you're in the wrong plane. It's so easy. Hopefully tomorrow with the elite teams that we're going to be doing injections 101, we're going to do this. 2-layer approach, supraperiosteal, subdermal, microdeposits, typical volume, 0.2 cc's for an entire tear trough. And guess what? Sorry, this is apology to the industry people here, that's 0.2 cc's of 50-50 blend. It's 1/10 of a cc. 1/10 of a cc for each tear trough, 1/10 of a cc for the upper lids, 0.3 for the forehead, the rest into the lips. I just used the full syringe and I've done forehead, eyes, and lips. Is that economical? It's unbelievable. Okay? Got to get you guys excited about this. I'm passionate about it. Bring the passion into the room. 78% improvement, 50-50 blends. And look what else happens. What happened to the dark area underneath her eyes? It's lighter. Why? Because as Kent has taught us for years, it's a combination of things. It's the hollowing under the eyes that causes the shadowing that makes it dark. It's the pigment in the skin, and it's the transparency of the vessels behind the skin. By filling it between the skin and the muscle, you've covered over the vessels that are causing the Tyndall effect. Okay? You've covered over the vessels causing the Tyndall effect. You've corrected for the scalloping, which is the shadowing, and all you have left is pigment. So with my bad back, I will bow to the derms because the derms know how to take care of that with hydroquinone, azelaic acid, whatever you want to use, and you're way ahead of the game. You give the patient a depigmentizer, you do this type of thing, they look unbelievable. Okay? So why do I do a bilayer technique? Because I was getting into problems with clumping and I was getting into problems with edema, so I went back to the anatomy lab and said, I don't understand something here, why is it happening? If you look at the orbicularis muscle, take a look at the nose over here. This is the orbicularis muscle. It's a donut muscle. It's a sphincter muscle. And it's attached medially above and below the medial canthus. So this is the nose. This is the medial canthus. So that when your eye closes tightly, you don't go up and down vertical. You go like this. It's a sphincter. Do you understand? You pull it in towards the middle of the eye. Okay? Great. Because it's attached to bone over here, if you put all your product down on bone over here, there is no retinacular ligament over there. It's muscle into bone. The orbital retaining ligament can't get there. It's muscle into bone. And your injection is intramuscular because you can't get under it. And I do not believe that you can inject subperiosteally. And I'll defend that to the end. I know people show me it can't happen. Trust me, when we try to lift up periosteum, if my friend Lee's here, if you try to lift up periosteum, you need an elevator and you've got to work like a devil to try to get the periosteum up off of the orbital rim there. So all your injection is going intramuscular. Now you put those little deposits, whether it's by cannula or needle over here, and the patient leaves the office, and what happens over the next month, 2-3 months, is she sometimes squints and says, ouch, or sometimes she looks into bright lights like I'm doing right now and she's squinting. And what is she doing to your product? She's kicking it in the butt, and she's squeezing it like a tube of toothpaste. My wife's tube of toothpaste, by the way, drives me crazy. She likes to squeeze it from the middle. So that's exactly what you're doing to the product. You're squeezing it from the middle. It can't go here because it's tethered, so where does it gather? Right here. So 4 months later, they come back, and they have that bulge over there, right there. There's the Tyndall effect. And companies will tell you, we don't have a Tyndall product. Bull. Every product Tyndails. Okay? And I talk for them all. Every product Tyndails. Some have more of a tendency than others, but take a look at this. This is water, and this is water with a little bit of particles in it. Sure, if you have a particulate, there might be an incidence of higher Tyndall over here. Okay, let's call it out the way it is. If this was Restylane, maybe you would have a higher Tyndall effect. But if you layered it very thin, you wouldn't. It's technique. Even water will Tyndall. Look at the blue of the water. That's why the ocean is blue, why the sky is blue. Water vapor. It's the blue wavelength of light, the high wavelength of light bouncing off. That's why when you look out onto the ocean, when you stand over here at the beautiful beach and you look out at the ocean, the deep ocean is deep, deep blue. But when you look down at the beach where you're looking for shells, it's clear because it's thin. If you can get a product that will layer thin in the area underneath thin skin, you should avoid a Tyndall effect. So here's a patient pre-treatment. Here's 1 year afterwards. Those are the little punctures. I put very small amount on bone because I know in this area it's going to clump. And in this area I'm safe because here muscle's not attached to bone and I have that glide plane I get under the muscle. So I'll put in 0.025. You're going to see this afternoon. We're just going to put in teeny tiny little bits. Okay? And then I'm going to coat over the top like a sandwich and leave the muscle alone and the septum, just like we do in our surgery now. We do these types of surgeries on blepharoplasties where we leave the middle lamella, the middle part alone. We go in transconjunctivally to play with the fat, sculpt it, remove it, whatever you want to do. And we do these things on the skin like laser, but we leave the middle part alone. Let's do the same thing with fillers. Then you get that. Lighter, brighter, and lasts forever. It's a lot of fun, I got to tell you. And we were talking with Kent about cheek optimization. We're going to look for that point because that is all the difference in the world when it comes to creating a light reflex. It's a vertical puncture, I call it the 5-point. Deep subcutaneous, subperiosteal, typical volume, 1/4 of a cc, and what you're creating is a light reflex. Product of choice, whatever you like, guys. A more robust product. Take a look at her immediately after injection. Look at the light bouncing off the cheek. This was 0.05 over here, 0.2 over here. This is a 1/4 cc of product. Look at the difference in the two sides of the face. You see the light bouncing off over here? You see the eyebrows up just from a little bit of temple fill? I want to ask you a question. Is this mouth neutral compared to a downturn over here? The answer is yes. Did I do anything to lift that mouth? No. Are you going to tell me that a 1/4 cc of product caused that lip to come up? I'll argue with you and say no. I look at the things that I'm doing and I don't understand them. Why would that lip be up? Because of the fact that we put product in over here. There's not enough in there to cause a physical lift of the corner of the mouth. What I believe is happening is that product is sitting underneath zygomaticus major. It's sitting a little bit underneath masseter, zygomaticus major. And zygomaticus major says, oh, I finally have a chair that I can sit in, I can relax. So the minor that's sitting next to it, because they're talking to each other, says, whoa, if you're relaxing, I've got to pull a little harder. That's zygomaticus minor pulling up on the corner of her mouth. I think we're resetting the way that muscles are interacting with each other. Because I can't get a result like that. I would have had to have filled the face with 30 cc's of fat. Okay? And this is Kent, what he's going to talk about very briefly, because we're going to be short for time. We'll talk about it briefly, but we talk about lights and shadows. It's important when you're injecting into the midface and other areas that you keep the light high and the shadow low. This muffin tray, if you want to call it that, is filled with muffins over here, and these ones look empty, don't they? Would you say this looks like it's projecting and this looks like it's recessive? Right. What about if I turned it around? Now which one's projecting? The one with the light reflex on top and the shadow underneath. So beyond giving projection, beyond giving volume, we're creating lights and shadows. You're never going to see a master at that better than this guy right here. He understands lights and shadows because he's a photography nut, and he understands how to create those types of things. We talk about piriform fossa. You can inject onto the bone of the piriform fossa where it's safe, bone or dermis, nothing in between because it's dangerous. It's a slow injection. Watch what happens as I finish the injection over here. Do you think these products have robustness? You're damn right they do. Look at this. Look at how the base of the nose has been elevated and the nose has been tilted. The things that you can do with fillers are just awesome. We can have so much fun with this stuff and stay safe. Dorsum of the nose, like Kent was showing you, midline is the safe area. We'll talk about that with the anatomy. When you do nasal tip injection, these are the areas that are sensitive. Let's make the experience great for the patient. Watch the technique. Let the nose fall onto the needle. She doesn't even blink. You stick a needle in the nose, they'll scream. You let the nose fall into the needle, they hardly feel it. Why? Because of the movement. Melzak's theory, a little bit of movement gets to the brain first. The brain can't process two types of sensations. Says, I'll handle the movement. Forget about the pain that's getting there later on the delta fibers. So you do that. And for the base, like Kent was talking, I do this all day long too. You put in with a small BD2 needle, you go sneak right there. A little bit onto the dorsum, and then you get this as an immediate result. Tipping up the nose angle, straightening out the dorsum, getting a little more projection on the tip. And we can do that even for the nostril sills. Patients who've had surgery that have that retracted nostril sill, I'm injecting very slowly. I always have my smart hand there too, but for the purpose of the video, I'm keeping a very slow injection and doing this to show you that you can actually fill the area between the lower lateral cartilage and the alar rim by doing it very slowly. I don't know if I have the picture. Can we speed it up and see if it's the end of the picture here? No, I think that's it. There it is. See before the notch? and now it's rounded.